Hi guys, good evening. Hello everyone, good evening. How was your weekend? Guys, can you all confirm you're getting me so we can start? Just by a show of hand, maybe.
Good evening.
Good evening, Alaude.
Sir.
I hope everyone can everyone actually hear me?
They've muted. Everyone is muted here. Maybe they should mute so that they can answer and respond to your greeting.
Okay. Yeah, Anita can hear me. It's good. Okay. So, how was your week actually? Have you guys had a great week?
Fine.
You went through the
Fine, sir.
materials as well.
Yeah.
Okay.
Yes.
I hope we all went through the materials that were provided in the classroom as well. With the pharmacology, did we have any problems with some of the questions? Mm, okay. I hope this helps. Okay. So, guys, you guys are all welcome back to like good week of our lesson. And today we're looking at the respiratory, cardiovascular, and the neurological system. So we'll just have a run through it. I just have to go through these various systems, check on the assessments of these systems, common clinical findings, rationales, and nurse intervention, like private nurse interventions we need to consider or take actions when you're looking at these various systems. Can we all see my screen?
Yes, sir. Yes,
Okay,
please.
okay, that's great. So this will just have a quick run through of these three systems, like just a revision, and we look at the assessments, like I said, the assessments, the nursing interventions, and some pertinent aspects concerning them. And then we, like as always, we look at some questions at the end to maybe test our knowledge on what we have discussed so far. And like I always say, I always like the class to be somehow interactive. So when we're discussing more, we are learning more. Like I said in our first encounter, there is no wrong answer, and we are all here to learn actually, right? And this is not like something new they're introducing to us. We've been through nursing school. We have been practicing. Some of us have been practicing for a while. This is just like a revision to jog our memory or to get us accustomed with practicing or taking the LPN exam. So participation, I think I really encourage that. In case there's any question along the line, you can always raise a hand, then you ask at any point in time, or if there's anything you don't understand or you face difficulty assimilating in the course of the conversation, you can as well just raise your hand and you ask as well. So we will start with the respiratory system. So we'll do general respiratory assessment and management. So looking at the general respiratory assessment, we will know the key actions in this system. They include monitoring breathing rate, right? Breathing rate, breathing pattern. You have to note the rate, the depth, if the patient is using effort or accessory muscles in breathing, right? You observe for signs of cyanosis. You check for chest symmetry. And you also listen for adventitious lung sounds and crackers. Those are all your respiratory assessments that you need to pay attention to or carry out. Okay. So after these assessments are being done, and we have identified some striking issues like identifying acute respiratory problems. I mean, we look at some key signs and symptoms associated with it. Some key signs and symptoms associated with it, like the acute respiratory problems. You have like pneumonia, you have pneumothorax, right? You have asthma exacerbation. So we'll look at those problems, look at the key findings associated with it, and some interventions or keynotes to remember. So first, let's take a look at pneumonia. So with pneumonia, in assessments, we will often find rapid shallow breathing and confusion. Excuse me. So in pneumonia, we find rapid shallow breathing and confusion. And we know these are signs of significant gaseous exchange problem, which is associated with hypoxia, and will likely lead to like respiratory failure. So the clinical assessment, we will have respiratory rates of 30 and above with confusions. And why will we have confusions? It's a question like why will we observe confusions in patients with pneumonia like so like I said, these signs like rapid shallow breathing and confusion, they are significant, like they show you there's a problem, like there's a significant gaseous exchange problem, which is associated with hypoxia, right? And with hypoxia, we know there's a decreased or diminished oxygen supply to tissues or organs. And we know the brain is very, very sensitive to oxygen deprivation. So if when there's like the slight decrease in oxygen saturation or oxygen levels in the blood or oxygen supply to the brain, you often see manifestations like the confusion. Or in severe cases, you have confusions and the decreased level of consciousness as well, right? Guys, we following? So our next thing we'll look at is hypoxemia. Hypoxemia. So with hypoxemia, we know the difference between hypoxia and hypoxemia, like I just mentioned earlier. With hypoxia, there is diminished oxygen supply to organs and tissues, right? While with hypoxemia, this is like just low levels of oxygen in blood, and that can be taken from the ABG, the arterial blood gas. Once you get the values and the readings, you get indications of hypoxemia. So clinical findings associated with hypoxemia, they will often include restlessness and confusion as well. And same reason I just mentioned, it's because you have diminished oxygen supply to the brain, and the brain is very sensitive to oxygen deprivation. Our next concern or acute respiratory problem we're looking at is asthma, acute asthma exacerbation. With this, we will have wheezing, because with asthma you have a narrowing of the airways, right? So it impairs gaseous exchange. So the patient is literally struggling to breathe. With that, you often observe wheezing. You listen to on auscultation, you hear wheezing, you hear diminishing breath sounds, you get confusion as well, and severe airway obstruction. With severe airway obstruction, now you have bronchial spasms as well. So in this case, the management, you have bronchodilators like albuterol inhalers. They'll be given to relieve acute bronchospasm. So the patient can actually breathe normally. So we try to establish a breathing pattern, normal breathing pattern. And another point we're looking at, it's pneumothorax. You know, with pneumothorax, air enters the pleural space, right? That is the space between the chest wall and the lungs, causing the lungs collapse, right? So when air enters the chest wall and when air enters the pleural space, causing the lung to collapse, you often, if when the lung collapse, you probably not get lung sounds on the affected lung, right, guys? Upon auscultation, if you have lung collapse, how will you get any lung sounds? Shows that the lung is not functioning again, right?
Yes.
Yes. So, like I mentioned, air enters the pleural space. That is the space between the chest wall and the lungs. And in this space, normally there's a negative pressure in that space, which enables contraction and relaxation. Like during contraction and relaxation of the heart, of the lungs. Sorry. So when air enters the space, it loses its negative pressure, causing the lungs to collapse. And upon assessment, like I said already, you have absent breath sounds on one side or the affected side. You also have sudden dyspnea, and these conditions, like, it requires immediate intervention. And the immediate intervention we'll be looking at is instilling a chest tube, though that won't be within our scope of practice, but we should know how to spot uh, these signs and symptoms of pneumothorax, and we should know how to assess or manage a chest tube when it's placed. If our patient has a chest tube, we know what to look for, abnormal or abnormal findings involving that as well. So, like I said, the immediate interventions will be instilling a chest tube, and this chest tube, it's meant to establish a negative pressure back in the pleural space. So, after the chest tube is placed, what do we do? We have to assess the patient again, and you assess the patient. You check the chest tube if it's functioning well, and you watch for bubbling in the water seal chamber, because the chest tube is connected to a water seal chamber, right? So you watch for bubbling in the water seal chamber, and you don't always watch when watching for when looking for bubbling or observing, you need to know that continuous bubbling is a problem, and intermittent bubbling shows that it's functioning well, because the chest tube now it creates sorry, the chest tube, it creates an exit path for the air that was trapped in the pleural space, right? So once the lung is the lung is expanding, it's pushing the air out through the chest tube, and when it's pushing the air out, you actually observe it. You will see the water sea chamber, it's bubbling, right? So if it's bubbling intermittently upon either breathing, it's okay. It's a one-way valve, so it's okay. But if it's continuously bubbling, it's a problem, because there's either a leak somewhere. And also you need to check
Hello,
for
sir.
blockages.
Hello, sir. Sir,
Okay, go on.
just a repetition on bubbling. I didn't get you clear. Can you just repeat?
On the chest tube,
Yes, on the chest tube.
so like I was saying, the chest tube placement, with the chest tube, it's meant to establish the negative pressure back in the pleural space. So let me see if the video can be stable now, because I don't know if is the video stable.
Yes.
Okay. So what I'm trying to say is this. On my right, you have this white pen I'm holding. On my left, you have this pencil. So this is our lung, right? And this is the chest wall. Okay. Can you guys see very well?
Yes, sir.
Okay. So this is the lung. This is the chest wall, and the space in between, you have the pleural space, right? So when air gets in here, like let's take for example, this is air. Air gets in here, the pleural space. So upon inspiration, the lungs, they cannot expand, right? So they collapse. You have lung collapse. The lungs, they collapse because the air here is blocking. It's giving the positive pressure, so it's pushing towards the lungs, so it cannot expand. Okay. So now, the purpose of the chest tube. Let's just say this is the chest tube. So once you introduce the chest tube, it gives a pathway for the air to escape, to go out. Okay. And when you're during breathing or inspiration, your lungs are expanding. When your lungs are expanding, they're pushing the air. The air is going out through the chest tube, and the chest tube is connected to a water seal chamber down. The purpose of the water seal chamber is probably to dissolve the gas going out of the lungs. Okay. So if when you're observing the chest tube, or you're observing the water seal chamber as well, and you see bubbling upon breathing, like intermittent bubbling, it shows that the chest tube is functioning well, because air goes out upon inspiration, it goes out to the water sea chamber. But then if you notice continuous bubbling, that shows a problem, like there's a leak somewhere around it. Okay. Guys, are we following?
Yes, sir.
Yes.
Yeah.
Okay. Is it understandable now?
Yes, sir.
Yes, sir. You can continue.
Okay. So in the care of the chest tube, like I said, you need to check for the bubbling. Intermittent bubbling shows everything is fine. Continuous bubbling, it shows like this leakage somewhere. That's why you need to check for blockages. Check for blockages or kinks in the chest tube, anything that will obstruct airflow away from the pleural space, the air escaping the pleural space into the water seat chamber. You need to check for that as well. So the next we'll be looking at is tuberculosis. So with TB, you know, the classical findings we often see with TB, you have the night sweats, right? Hemoptysis, like a blood stain mucus. Okay, so once we get these indications, what do we do? What is our intervention as nurses once we observe these findings, like indications of TB?
Please, the question again.
Our interventions as nurses once we get the clinical indications or findings of TB, like a patient complains of night sweats, and you observe hemoptysis, like the blood stain mucus.
I think we start by putting this patient on airborne precautions.
Good. So with that, like you said, once we observe that, we report and prepare for isolation. Okay. Infection prevention measures, they should be put in place immediately. Like you said, airborne precaution. Okay. So our next step we're looking at is COPD. Can someone help us with the oxygen saturation level, like the acceptable oxygen saturation level for the COPD patient?
Yeah, 88 to 92%.
The acceptable oxygen saturation rate for COPD patient.
Uh, 92, between 88 to 92.
Sorry.
It's usually below 95.
I think it should be between 88 and 9. Is it 9? I don't know if it's 95. Between 88 and 95. I'm not sure.
88 to 92.
Exactly. It's 8 to 92. So the goal is to keep or maintain the oxygen saturation rate at 88 to 92 in COPD patients. So that's what we have to watch for. So in case of a situation of exacerbation or worsening of the COPD, what do? We encourage pro-sleep breathing. Okay, and this is to maintain the oxygenation by prolonging the exhalation phase of respiration. That's by preventing trapping of air in the alveoli, and it encourages gaseous exchange. And with sufficient gaseous exchange, you have improved O2 saturation, right?
Hello, please,
So
I have a question.
go on.
Why is it that in the COPD patient, they don't need an oxygen saturation of around the normal one, around 9900, 98?
With COPD, we know with COPD, it's a chronic condition where either the alveoli or the air sacs are being damaged or they're destroyed, right? So you cannot have an oxygen saturation of 98 or 99 like a normal functioning person. It's not like something where it's not like a reversible something that they'll they'll correct and you have the oxygen saturation back. The alveoli or the air sacs, they've been destroyed either by emphysema or chronic bronchitis, like they're being compromised. So we are trying to maintain a stable oxygen saturation to prevent respiratory failure. And it's often acceptable that an oxygen saturation of 88 to 92, it's sufficient for sustaining life. Okay.
Okay, sir.
So, like I said, in the situation of exacerbation, we encourage post-sleep breathing. And like with post-sleep breathing, like during exhalation, like you're breathing out. So you breathe out, like you extend the exhalation period of respiration. During that period, the air, since the alveoli have been destroyed, gaseous exchange is interrupted. So during the exhalation period, it gives enough time for all the air that is trapped in the alveoli to go out, which improves gaseous exchange and helps in oxygenation. Okay. So this, after we have ascertained these conditions, some of them, some of these cases, they can require procedural corrections like surgeries, or some of them will have invasive procedures to investigate more, like a bronchoscopy. Okay, so we need to also know that we have to care for like patients that have undergone either post-op or post procedural like post procedures, post diagnostic procedures. And with this, you have prevention of atelectasis, you have post bronchoscopy care, and you also have like chest tube management, which I mentioned already. Okay, so looking at atelectasis prevention, that's just like preventing lung collapse. So with that, the goal or your main objective is like helping the alveoli expand and you keep the lungs clear, okay, to prevent collapse. So this is very, very essential in the recovery, and you need to encourage early ambulation as well. So adding to that, you have to use incentive spirometers, where the patient actually the patient places the mouth on the exit part and then sucks in air for the piston to move to the mark. When once you're taking in air, it goes to the lungs, it's helping the lungs expand. So you're preventing lung collapse. Okay. So another procedure we need to look at the management is the chest tube, which I mentioned earlier. Like you need to monitor for bubbling in the water sea chamber, and then you need to check if there are any obstructions in the tube, like the kinks or secretions that will prevent backflow of, like that will prevent the exit of air from the lungs. or from the pleural space. Okay. Another thing we look at is bronchoscopy, post bronchoscopy care. So with this, since the gag reflex is being suppressed during the procedure by anesthesia, right? We need to assess the gag reflex. And why do we assess the gag reflex in post bronchoscopy care? It's a question, guys. Why do we assess the gag reflex in post bronchoscopy care?
Is it to prevent aspiration or choking? I'm not sure.
Exactly. No, you're actually correct. So since the gag reflex is it's suppressed with anesthesia, right? Any foreign object can easily get into the airway and cause airway obstruction because there's no gag reflex. So after bronchoscopy, you need to assess the gag reflex before introducing food or water. In case something gets there, the patient is able to it's able to gag it up, right? So we assess the
Right.
gag reflex to prevent aspiration, like you said.
So, sir, please, how is that assessment done?
So in assessing the gag reflex, you use a tongue suppressor. Okay, you use a tongue suppressor, and then you touch the tonsillar the tonsillar muscle, like you touch it. If the patient gags out, it shows that the reflex is back.
Okay.
Okay. Any question again? Another question?
Sir, please, concerning the spirometry, I saw a question about
Okay.
the how deep, I mean, the deep and then is it shallow? No, the deep and fast or slow of taking in the air. Is it when you are taking
So
in the air to use the spirometry, do you take in the air fast or slow? As for the deep, I know you have to take it deep, but is it fast or slow?
you take it, you inhale slowly. Like it gives enough time for lung expansion. The purpose of
Okay,
that is
sir.
to the purpose of that is to enable lung expansion, right? So you inhale, and once you're using it, you are inhaling and you're looking at the cylinder. So once the piston moves up to the graduated point, right? You hold and then you exhale. Normally,
Okay,
in
sir.
a normal situation like this, once you're inhaling, you actually feel your lungs expanding, right? Like you're taking air. The lungs are expanding, right? So that is just to enable the lung expansion.
Okay, sir. Thank you.
Sure. So I think we have touched some of the critical points in respiration and or the respiratory system. Let's look at the cardiovascular. So in the cardiovascular, we know it's like just the pump system of the body, right? The main purpose of the heart is to pump blood. It's not to fall in love, guys. I hope we know that. Guys, it's a joke. I'm hoping you all got the joke. Like the purpose of the heart is to pump blood, not to fall in love. Yeah. So the with the cardiovascular system, it requires prompt intervention because it's a closed valve system, and any obstruction in a part or section of the body that returns blood to the heart or takes blood from the heart, it can be fatal or felt all over the body. So this requires prompt intervention or assessment. Why? To find out any obstructions or problems and restore normal function or reduce the extent of damage in case there is any. Okay, so let's take a look at some critical findings to report immediately when you're looking at the cardiovascular system. So with the critical findings that require immediate attention or escalations, you have the MI, right? You have like a hypertensive crisis, right? You have like a cardiogenic shock. So with MI, if let's just say a patient comes in the ER complaining of chest pain radiating to the left arm or jaw, instinctively with our nursing knowledge that those are clinical presentations of myocardial infarctions, and it's a medical emergency, right? Guys, we together?
Yeah.
Yeah.
Okay. So once assessments like this are done or we get these findings, you know, you can start oxygen therapy or you continue oxygen therapy, which it's meant to improve perfusion to the heart and decrease the extent of damage or death of the heart muscle. Can we get the difference between the myocardial infarction and angina pectoris? The difference between myocardial infarction, MI, and angina pectoris? They are all chest pains, right?
Yes, they are all chest. But so please let me try. I think with the angina, it can be relieved by nitroglycerin. By the MI, I think when you take the nitroglycerin, it can relieve it.
Yeah, that's absolutely true. So, you know, MI, it's like just ischemia of the heart muscle, either by occlusion, right, or vasoconstriction. So it can be relieved by nitroglycerin, which is a vasodilator. But with MI, that's like this the muscles of that of a section of the heart they're already dying, so it cannot be relieved by nitroglycerin. You get the pain like someone sitting on your chest. So once we get these findings, we have to report immediately, escalate for immediate or prompt intervention. So our next critical findings that we have to report immediately, we have hypertensive crisis. So with hypertensive crisis, we have blood pressure going from like 180 on 120 above. That's like an emergency we cannot ignore. And with that, you have symptoms associated with it, like blurry vision, severe headaches. Okay. Uh, Another finding we have is a cardiogenic shock. Can someone help us with the signs and symptoms of shock generally? The signs and symptoms of shock.
I think restlessness, low BP, sweating, increased heart rate. Yeah, yeah.
Okay.
I think someone can answer.
Yes, you're absolutely right, Francisca. Shock just means like there's low perfusion, like low blood supply to a certain part of the body, or which is it might be obstructive, cardiogenic, anaphylactic. Like we know the different types of shock, right? So in this case, we are looking at the cardiogenic shock. So where the heart cannot pump blood adequately. Okay, so with this, you still see the same signs that pertain to shocks too. You have like the cold clammy skin, like you said, the low BP, tachycardia, right? These are all the classic signs of shock. So with that, it requires prompt intervention as well. So since we have looked at these various conditions, we'll take a look at some cardiac medications as well. And with this, I think we'll have to refer all reference to what we discussed last week in pharmacology, because we have like similar medications there. We have medications like digoxin, you have diuretics, you have anticoagulants as well. Okay. So with digoxin, can someone help us recall what we talked last class about digoxin, patient assessment, key considerations before administration, and assessment after administration?
You said we should check the heart rate, the pulse, if it's not less than 60.
Correct. Yes. So you assess the patient before administration, and what assessments do you do? You check the apical pulse, right? And if it's less than 60, it's an indication that you hold the medication and notify the provider, right? And after administration, what do? You watch for toxicity. Last class, we talked about digoxin being high alert medications, right? So during
Yes, sir.
administration, you watch for toxicity. And how do you watch for digoxin toxicity? How do you watch for digoxin toxicity?
So I think if I remember right, you said one of the sign would be halos of, I think, light.
Okay, that's correct. So the patient often complain seeing halos around light, like yellow or green halos around light. Okay. So once you get a patient complaining about that, which you just administered digoxin, those are classical presentation of digoxin toxicity, which requires prompt intervention. Okay. So another cardiac medications we're looking at is like diuretics. So we know there are two types of diuretics. Which and which? The two types of diuretics.
Potassium sparing diuretics.
Okay. Correct. That is one. You have potassium sparing and potassium wasting.
So they look direct.
It just means. I mean, we are looking at these two, potassium sparing and potassium wasting, because the heart muscles are very sensitive to serum potassium level. So any change in the levels, you often see it in the EKG. I mean, they have severe cardiac manifestations. So when administering this medication, like the potassium wasting diuretics, you need to do what? You assess for serum potassium levels, right? You assess this to prevent what? Hypokalemia, since you're administering potassium wasting, right? And same
Okay,
goes
sir.
for potassium sparing diuretics. So when administering that, you also check for the serum potassium levels. Can someone help us with the serum potassium levels? Normal serum potassium levels.
3.5 grams per kilo, 5 per 2
5.0,
Exactly, 3.5 to 5.0. So during administration, we check for these levels. When you're administering potassium sparing diuretics, it will retain the serum potassium, the level of potassium in blood, right? So you need to monitor as well. In case of hyperkalemia, how will we often see that manifestations in the EKG?
So there will be tall T peaked wave.
Okay. Now someone has something else to add. Okay, so you are correct. In the EKG, the manifestations you often see peaked T waves, right? And widened QRS complexes. So those are all clinical findings or indications of hyperkalemia. Once you see that, what do you do? What's our nursing intervention? Like I said last class, once you're administering any medication or a high alert medication, if you notice any abnormality or the medication causing an adverse effects, what do? You hold immediately. You stop, right?
Yes, you should stop
You
immediately.
stop. Yes, you stop. You assess. Notify.
Notify. Yeah.
Exactly. And how do we correct hyperkalemia? Does someone have an idea?
I think we can correct it with the use of drugs, giving potassium wasting directives, and you treat the heart effects as well, cardiac effects as well.
Okay.
Can also
Yeah.
prevent potassium supplement, high potassium supplement.
Okay.
And you can also use
Like
insulin.
insulin. Good. Those are all viable options. So our next medication we'll be looking at is anticoagulant. So we talked about anticoagulants last class already. You have like the heparin, the warfarin, and what are the assessments before administration or during administration of anticoagulants like we discussed last class? Can someone recall?
We talked about bleeding risk. You assess for bleeding risk.
Okay, exactly. Check for bleeding risk, bruises in the mouth, check for bruises in the gums, stuff like that. Then you check for GI bleedings, right? Like black tarry stools or uh, brown emesis, right? And during monitoring, you check the INR or the APTT, depending on the anticoagulants that's being administered, right? And the antidotes as well, they should be present. Okay. So another medication, the next medication I'm looking at, it's vasodilators, and the example here we're talking about is nitroglycerin. We made mention of it already earlier. It's a vasodilator. So uh, with nitroglycerin, we know it can significantly decreases the blood pressure. So before administration or during administration, we are often supposed to, not we are often, but we're actually supposed to educate the patient, tell them to sit down or lie down during administration. This is to prevent like falls, right? During severe hypertension, the patient presents fall risk. So we are supposed to ask them to sit or lie down. And like we discussed last class, before administration or during administration of any medications, you assess high risk medication, you assess the patient. So with the nitroglycerin, with the vasodilator like nitroglycerin, you assess the patient as well. You check for the blood pressure. You check if the BP is like 84 on 50 or below, you hold the medication. Okay, you hold, you notify the provider. And then you also assess if the patient is taking some other medications that have nitric containing compounds. Like let's say sildenafil, the patient is on sildenafil, Viagra, right? You're not supposed to administer that. Okay. Our next medication, we have beta blockers or the LOLs, right? And with that, you assess the blood pressure before administration. Are we together? Guys, are we together?
Yes, sir.
Yes, yes.
No. Good. So next thing we're looking at is heart failure and heart failure management. So like I said earlier, the main purpose of the heart is to pump blood. So if the heart fails and the heart cannot pump blood or redistribute blood to the system, you have a problem. You either have a problem like there's poor oxygenation, which is a vital problem because the heart will not be able to pump blood from the lungs to the exterior or take blood back from the exterior from the extremities. So there's disruption in blood supply. And here we have, of the right sided heart failure and the left sided heart failure, right? With the left side, the left ventricle, it cannot pump oxygenated blood, right? You cannot pump oxygenated blood from the lungs to the body. So it cannot redistribute the blood from the lungs to the body. So what happens? The blood now backs up back into the lungs. And when the blood backs up into the lungs, like what do you have? Pulmonary edema, right? you get upon auscultation, you get crackles in the lungs, right? And
Yes, sir.
the patient, yes, and the patient will often experience difficulty breathing when lying down, because when you lie down, there's limited room for lung expansion, and the lungs are filled with fluid again, so there's like difficulty breathing. Okay, and then with right-sided heart failure, like the right ventricles, like they are weak. I mean, they're causing backup of blood in the systemic circulation, so the blood cannot re-enter. It cannot re-enter the right ventricle, so it stays in the systemic circulation. And what happens then? You start seeing the signs like peripheral edema, right? Rapid weight gain in all those. Okay. So once we have assessed and sorry, you often find oh, sorry guys.
Sorry.
So after assessment, during treatment, there's often you get diuretics are being administered to reduce vascular congestion or backup, right? With diuretics are administered as well to reduce the cardiac preload. The cardiac preload, it reduces the cardiac workload as well. If the amount of fluid in the body it's being excreted, there's less. If the heart has it has less work to pump, right? So we're just trying to reduce the cardiac workload here, since the heart muscles they are unable to either pump or receive, like they are weak in that aspect. So in the management or taking care of patients like that, patient education is very vital. Like you educate the patient on limiting the amount of sodium intake, right? Since we are administering diuretics to reduce fluid volume, we should also limit the amount of sodium intake, since we know where sodium goes, water follows. Like sodium promotes water retention. So the patient should actually reduce sodium intake for better effectiveness. Okay. And you reinforce patient teaching and assess patient understanding about weight gain to side or pick up early, early signs of worsening conditions. So you teach the patient about getting their weight either at the same time every day with either the same clothing or similar clothing. That is to get the accurate weight. Okay. So after looking at the heart, we'll probably take a look at the take a look at neuro. Yeah. Take a look at can really happen. We look at the neurological system. So with the neurological assessment, it's very, very important. Going by the levels of organ vitalities in the body. The brain, it's like up there. Okay, so any changes or conditions affecting the brain might be life-threatening, which can result to either temporary problems or most likely permanent, irreversible problems. So interventions are very, very important, because any change might have devastating effects, right? So we need to be able to spot life-threatening conditions like increased ICP, CVAs, spinal cord injuries, and other neurodegenerative conditions too. Okay, so let's take a look at increase in intracranial pressure and cerebrovascular attack. So we know with the ICP, when the pressure exceeds 15 to 16 millimeters of mercury, the clinical manifestations or findings, the patient, you often experience early signs like a severe headache, right? Vomiting, decreased level of consciousness, and pupillary changes. And then with the late signs, you often see the Cushing's triad. Can someone help us with the Cushing's triad? The three key findings of the Cushing's triad. Yes, go on, Florence. So with the Cushing's triad, you have three hallmarks of the Cushing's triad. Like, okay, go on, Dennis.
The person's drive will be there will be hypertension, low heart rate
Okay,
will be there, and there will be regular respiration.
excellent. So those are the three. Yes, those are the three hallmarks. Like Cushing's triad, they tried the three. Those are all the three aspects there. So the Cushing's triad, this is like this is late signs of increased intracranial pressure. And in pediatric clients, you often observe, you see a bulging fontanelle and irritability as well. These are your observations. So these are all emergency situations that requires escalation immediately. Another problem we often encounter, you have like a traumatic brain injury. With the traumatic brain injury, we will see you often have signs or visible signs like raccoon eyes, right? Like bruises under the eyes. You know raccoon eyes, right? You have raccoon eyes. You have battle signs. You see bruises here and bruises behind the ear. Those are all indications of basilar skull fractures, right? And then you often see leakage of CSF. And CSF, it's a clear white fluid. It's a clear fluid. So you see it leaking from the nostrils or the ears. Okay. So in this aspect, what do? You position the patient to sit at a 30 to 45 degrees angle. With this position now, you promote you facilitate drainage of the fluid through the jugular veins, right? So this reduces the ICP. Okay, we good? You have a question? So another problem we're looking at is CVA, like we said. Looking at acute stroke. So we know with stroke. Oh my God! Sorry. With stroke, immediate or prompt intervention is very, very vital to either cut down the extent of the damage, right? Because if it's delayed, you have maybe irreversible brain damage. So prompt intervention is very, very important and necessary. So with stroke, we need to remember the FAST acronym, right? The FAST acronym, like you have facial drooping, speech problem like slurry speech, right? Like I said, you have facial drooping, arm weakness, you have slurry speech, and then you know the time. Okay. So after all these assessments are done and you know the time, prompt intervention is very, very vital. Another acute condition we're looking at, I think it's seizures. So with seizure management, our aim is stabilizing the patient and preventing aspiration. So we know managing abnormal electrical activities in the brain, it's very, very essential in preventing any secondary injuries associated with it. And we know the four main types of seizures, like the tonic, right? Tonic-clonic, myoclonic, absence seizure, atonic seizure, right? But we'll be looking at the more severe ones, like the tonic-clonic seizure. So with this, our priority intervention will be maintaining a pattern airway, right? And you need to avoid introduction of any objects in the mouth. Do not put anything in the patient's mouth. Maintain a pattern airway, and you don't restrict the patient. Don't confine the patient or restrict the patient. Okay. After assessment, you try to get the area free of any harmful object in case the patient might hurt his or herself, and you make the patient lie on the side, which is important because it will help drainage of any secretion, any mucosal secretion, right? And then as well, you note the timing and the duration of the seizure. So in fact, let me ask this as a question. What's the difference between the seizure and epilepsy, like status epilepticus? The difference between seizure and status epilepticus? Can someone try?
Seizures are temporary and epilepsy is chronic, characterized by episodes of seizures.
Okay, those are like epilepsy. But now, looking at status epilepticus, like you said, they all involve seizures. But now the duration is the problem. Any seizure lasting longer than 5 minutes, right? It's categorized like it's classified as status epilepticus, which is an emergency as well. Because once you're seizing, your brain is deprived of oxygen. Once the abnormal electrical activities are happening in your brain, it deters brain function and the deprivation of oxygen. So if your brain is deprived of oxygen for more than 5 minutes or so, I mean, brain hypoxia will lead to like death of cells, brain cells, which we know are irreversible, right? So seizures lasting longer than 5 minutes, status epilepticus, and it requires prompt intervention. So you notify the provider, and the patient is being started on medication and treatment. You have treatments like phenytoin. So after teaching is being done either by the RN or the provider, you have to reinforce the teaching like the patient should be the patient should take the medication either on the same time every day consistently. Okay, strict adherence to medication regimen. Very, very important. Okay. So now let's take a look at some neurodegenerative disorder or neuromuscular disorders. So with that, here we're looking at the assessment. We're looking at assessment management of disorders like Parkinson's disease, okay, myasthenia gravis, and GBS, that's Guillain-Barré syndrome. So with Parkinson's disease, what as nurses, what would be our key points of note? The Parkinson's disease, it's a neurodegenerative disorder that is caused by like damage of dopaminergic neurons in the brain, right? So you have classic signs like resting, tremors, shuffling gaits, and muscle rigidity as well. So it's important for us to like implement 4 precautions, right? Implement 4 precautions. You assess for dysphagia, right? And you often encourage frequent meals with soft foods. Why? This will prevent aspiration. Frequent meals with soft food, it's easy to swallow and it prevents aspiration. Okay. So next, look at the myasthenia gravis, MG. This guys, are we following? Do you have any question? Is there a question, please? Okay, let's continue. So with MG, myasthenia gravis, this it's an autoimmune disorder, right? That is caused by destruction of the acetylcholine receptors, right, at the post synaptic region of the neuromuscular junction. So in that aspect, you often have muscle weakness, right? So upon assessment, you have generalized muscle weakness and the drooping of eyelids. You have dysphagia and respiratory distress. So airway maintenance, it's actually a priority today. Okay. The next, you have Guillain-Barré syndrome, which is also an autoimmune disorder that causes destruction of the myelin sheath of the nerves of the peripheral nervous system. So in this case, we know the peripheral nervous system, they carry impulses to and from the peripheries, like the extremities of your body, right? So if you have destructions of the myelin sheath, neurons impulses, they cannot be transmitted to and from the extremities. So you often see characteristics. So it's often characterized by you have ascending paralysis. Okay, you have ascending paralysis. You have muscle weakness as well. And things with ascending paralysis, you start losing sensation from your legs coming up to the diaphragm, intercostal muscles. So once you're losing sensation or you're losing nerve action there, the muscles there, they lost their function as well. So if intercostal muscles and the diaphragm, they lost its function, that's leading to respiratory failure, right? So it requires prompt intervention to prevent respiratory failure. Okay. So those are like the key assessments or the key points we're supposed to look at in nearly all what we have talked on today. So do we have some questions? Do you have any questions concerning what we just discussed? Okay, if not, let's take a look at some few questions. Like, let's take a look at this quiz just to refresh or test our knowledge on what we have just discussed so far. Okay, are we together?
Yes, sir.
Okay, so question one reads, what is the most critical nursing assessment to perform after a client has undergone a bronchoscopy, and what is the rationale for this action? Critical nursing intervention to perform.
I think as we said earlier, you check for the gag reflex to um, ascertain the risk for aspiration.
Okay, that's correct. Perfect. So, like we said, we discussed earlier, you check for gag reflex, right? Ascertain the risk of aspiration. Our next question, you have explain the purpose of pulse sleep breathing for a client with chronic obstructive disease and how it improves their oxygenation. The purpose of pulse sleep breathing in COPD. Guys, can someone recall what we talked about pulse sleep breathing in clients with COPD and how it improves their oxygenation? So, like I said earlier, COPD, you're extending the exhalation phase of respiration to remove what trapped air in the alveoli. And once that is done, it improves gaseous exchange, right? And improves the gaseous exchange leads to improve oxygenation. Okay. Are we good? Are we okay with that?
Yes, please.
Okay. So the third question, describe the classic assessment findings that would suggest the client has developed a pneumothorax.
So I remember you said there will be either decrease or absent lung sounds at the affected portion.
Right, that's correct. You have absent lung
Yes,
sounds at
sir.
the affected site. Dennis, you have something to add?
Yes, sir. Yes, sir. You made us understand that in pneumothorax there is an air trap in the pleural space. That's the space between the chest wall and the lung. So this one prevents the expansion of the lung. So in pneumothorax during auscultation, you hear crackles present.
Not really crackers. With crackers, you have crackers with heart failure because of backed up fluid. With pneumothorax, you won't actually get any lung sounds because the lungs actually collapse, so it cannot expand. So you don't get any sounds upon breathing. Okay.
Okay, sir. Yes, sir. Okay.
Yeah. So you get difficulty breathing, you get dyspnea, and you have absent lung sounds on that affected site. Well, question 4 states a client with heart failure is prescribed diuretics. Explain the primary therapeutic goal of this medication in managing heart failure.
Sir, please come again with the question.
The question reads, a client with heart failure is prescribed diuretics. Explain the primary therapeutic goal of this medication in managing heart failure.
Okay. So please, I think to alleviate the symptoms of fluid overload in the or congestion in the patient of heart failure.
Okay, so but like you said rightly, by administering diuretics, it reduces the fluid volume of the body.
Yes, please,
Once
overload.
yeah, yes, once enough fluid is excreted, you have decreased fluid volume, you have decreased overload. You have decrease. That improves. That reduce the cut the work rate of the heart. Okay. Question 5. So what key safety instruction must a nurse provide to a client who is prescribed sublingual nitroglycerin for chest pain? Key safety instructions a nurse must provide to a client who is prescribed sublingual nitroglycerin.
I think the nurse should check the apical pulse, and if it is less than 60, the nurse should hold. No, please. I think I'm messing it up. Sorry.
Hello, sir.
Francisca, if you think you're mixing it up, then you got yes, go on, Cynthia.
Okay, so with sublingual nitroglycerin, it means that it should be placed under the tongue and not swallowed full.
That's correct with the patient teaching and medication administration. Good.
And I think you should also educate the patient on the risks of fall because, as you earlier said, it causes vasodilatation. So the patient might, if the BP goes so low, the patient might fall when trying to stand up.
Good. So since it causes vasodilation, in some cases you might have severe hypotension. With severe hypotension, you have the risk of fall. So you educate the patient or you ask the patient to sit or lie down during administration. Okay. So our next question 6. So what are the 3 classic signs of DVT? Right? Why do they require urgent evaluation? 3 classic signs of DVT.
So 1, the swelling of the leg.
Good.
There's persistent pain.
Right.
So there is skin changes.
Sorry, I can't hear you well.
Skin changes.
What changes?
Skin changes.
The skin.
Oh yeah, right. Yeah, so like you have color change, right? Swelling, pain, and the leg. Okay. And why does it require urgent evaluation?
I think it's, if left unchecked, can cut blood supply to the affected limb.
And to prevent the dislodgement of the clots into the pulmonary system too. cause pulmonary embolism and others.
Correct. You guys are correct. That's great. So these are all reasons is required like urgent evaluation. So question 7. So they said list the primary signs of increased ICP and explain their significance. The primary signs of increased ICP. The primary signs we talked about vomiting, right?
Yes, and
Severe
headache.
headache, vomiting. Yes. Severe headache, vomiting, blurry visions, right?
Yes, sir. Contact level consciousness.
And yeah.
Blood vision.
So Anita, do you have something to say? Go on.
No, sir.
Okay. So looking at question 8, you have what is the priority nursing action when a client is having chronic seizures, and what actions should be avoided? The primary nursing action when a client is having chronic seizures.
Says the primary action is to ensure patient safety. That's protect the patient from harm during the seizure. And then you do not force anything into the patient's mouth while the
Okay.
patient is having the seizure.
Good. So these are all important, like so you maintain a pattern airway, okay, to prevent aspiration. You prevent falls, like you said, patient safety, access of prevents fall, right? And what actions should be avoided? Like you mentioned, you don't introduce anything into the patient's mouth and you don't restrain the patient. Okay. So question 9 states describe the initial nursing interventions for a client with a spinal cord injury who is experiencing autonomic dysreflexia.
Sir, please, the question. Yeah, it's okay.
Question 9. Can you see my screen?
Yes, sir, please, you can now see.
Should I read it all over again?
No, sir, it's okay.
Describe the nursing, the initial nursing intervention. Okay, okay. So first of all, what is autonomic dysreflexia? Can we tell? So with spinal cord injuries, a patient might suddenly come up with a sudden high blood pressure. Okay, and it's often visible. Or you can often find it in patients with spinal cord injuries from the T6, right? The T6 or above. So with that, you have a severe hypertension, immediate increase in blood pressure. And since it's affecting the T6, the T region of the spine, the thoracic region, what does it innervate? Breathing and respiration, right? Right?
Yes, sir.
So in that case, you remove you remove any constrictions, and then you elevate the head of the bed. Okay. So our last question 10, what is a cushion stride, and what does this, what does it present? What does its presence indicate in neurological assessment? The cushion stride. We talk about bradycardia, hypertension, irregular respiration, right? The three hallmarks. And what does it indicate? Those are light signs of increased ICP, right? So that's what we had for discussion today. Always please, you guys always endeavor go through the notes or the study materials available. Okay, and make sure
Okay.
to answer the various practice questions that will be made available. They are already available right now on the platform. So make sure to answer them when you submit, follow them, and then publish the results. And then with our discuss, we can discuss the questions that were posing difficulties to uh, most of the students. Okay. Do you have any questions? Okay. If you don't have any questions, I think that would be for our class today, guys. So see you guys next week, right?
Thank you, sir.
Okay. You're welcome. See you same time next week.
Thank you.